Good afternoon and welcome to Optimizing IT to Reduce Physician Burnout, a Health System CIO Media Inc. production sponsored by DSS. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO, and I'll be your moderator today. We're looking forward to some audience participation. You can send in your questions and comments at any time in the Q&A box, and we'll take those later in the program. We're also going to have a little poll that we'll do later in the event, and we'll have our panelists look at the results. Just a nice way to view the screen today is you click on the top center, get it in side-by-side mode, then you can slide the divider to get the video boxes and the slides the size you like, and it should say speaker view in the top right-hand corner. Just so you see how we're going to spend our time today, we're going to go about, I would say, 40 minutes or so with our main panel discussion featuring Dr. Dan Nigrin, SVP of IS and CIO at Boston Children's Hospital, Dr. Brett Oliver, CMIO at Baptist Health System of Kentucky and Indiana, Chuck Podesta, Interim CIO at UConn Health, and Christopher Kunney, Chief of Strategy with DSS. So let's jump right in. We got a nice panel today, and we're going to have a nice discussion. Let's get an overview of your organization and role. Dan, let's start with you.
Thanks, Anthony. Thanks, everyone, for inviting me, and I'm looking forward to a great session today. So Boston Children's is a 415-bed academic teaching hospital in Boston, obviously. We're the primary pediatric teaching facility for Harvard Medical School. I've been a CIO at Boston Children's for a long time, 20 years now, and actually 25 years at the organization overall. I also wear a clinical hat. I'm a pediatric endocrinologist there. All that said, I'm about to leave, actually. I recently announced that I've accepted a new role up at Maine Health, Northern New England's largest healthcare system, servicing obviously Maine as well as New Hampshire, roughly 12 facilities up there. So looking forward to that as we cross into the new year.
Very good, Brett.
Yeah, thanks for having me. I'm Brett Oliver, family physician by clinical background, still see patients 1 day a week. And for the last 7 or 8 years, I've been in IT, been the CMIO for Baptist Health for the last 4 years. We are a 9-hospital system, about 20, depending on COVID surge needs, up to 2,400 beds across our system, medical group of about 1,300. And I got involved in IT, asked to be the medical director for our EHR rollout, not having a clue what I got into. And then the guy that brought me into it retired, and I took his job. So glad to be here and look forward to the conversation.
Very good. Chuck?
Thanks, Anthony. Yes, as Anthony said, I'm the interim CIO at UConn Health. UConn Health is a medium-sized academic medical center in central Connecticut, and it's made up of John Douglas Hospital. We have 2 actually schools of medicine. One is a physician school of medicine. The other one is a school of dentistry, and then also have a large clinical research program as well, which I'm in charge of as well. Prior to this, I was at University of California, Irvine Health, and been a CIO for 25 years. Started here at UConn as an interim late January, and within about a month, everybody knows what happened with COVID. So been focused on that probably for the last 10 months. And going forward now with the surge, I think we're all focused on that.
Very good. Christopher?
Hi, Anthony. I'm Christopher Kenney. I serve as Chief of Strategy for DSS, and specifically with the focus around our commercial line business. For over 25 years, DSS has provided health information software development and integration services that's used by thousands of clinicians and administrative staff nationwide in both the public and private sector. We have a very extensive portfolio of products and solutions that are used to automate healthcare organizations. DSS is, for those 25 years, has really been leading health innovation by creating solutions to improve revenue cycle, regulatory compliance, interoperability, and above all, patient care. We are DSS again is one of the nation's leading IT leaders. We've been recognized for 4 consecutive years and since 2018 as a health informatics 100 company. My role as chief of strategy is to help the organization take a very bold leap to launch a next generation cloud-based electronic health record system that we affectionately call Juno EHR. We're excited to introduce this product to the inpatient market, and we believe that the time is right for a new solution to come to start to disrupt the market. So I'm excited to be here and look forward to the conversation today.
Very good. Thank you. All right, Brett, let's start with you. Regarding the applications that physicians must use in the hospital setting, what are the main points of irritation or annoyance that contribute to burnout?
Oh, gosh. It's a great question, and you can look at it kind of at a macro or micro level. On a micro level, depending on the physician, depending on their workflows, depending on their role, multiple logins, that kind of aggravation. We just recently changed our organizational password policy to a 16 character for very good reasons from a security perspective, but trying to sell that to my colleagues has been quite a challenge. On a macro level, though, there's the interoperability pieces, meaning, even though we've made leaps and bounds in exchanging information, there's still black holes of skilled nursing facilities, things like that, that when a hospitalist or a specialist gets a patient in the hospital, trying to figure out what happened prior to their arrival. And then on the other hand, there is sometimes an over-reliance on technology, and it's an annoyance, it's a point of irritation when traditionally we would pick up the phone and I would call Dan and say, hey, I need some help with this diabetic child, and just have a brief conversation. Now it all has to be entered in the computer, and that's sufficient. And from the person receiving the consult, that is oftentimes insufficient, and it's aggravating. And then from a hospital utilization standpoint, trying to understand why these consults were done. Are we over consulting on patients, under consulting? It can be a serious point of aggravation as well. So technology certainly is part of the aggravation and can provide some of the solutions, but I think you need to look at each issue separately.
Okay, very good. Dan?
I think all of those things, obviously, that Brett just mentioned. The phrase that you always hear used is that clinicians are not working at the top of their license, right? They're not being doctors, nurses. They're being scribes and administrators, really. And so that's the sort of the general vibe that I think irritates people. When you couple that with the stresses on clinicians nowadays, with the need that healthcare organizations have to get more volume and throughput through their organizations. So when the time that you have with each patient is so limited already, and then when you layer on some of this administrative work, it's not administrative really, it's part of the clinical care of the patient, but it's viewed as administrative. I think that's what really irritates the clinicians. What I'll also say is that I think there's still a frustration at the overall user experience with these systems. They've obviously improved over time and they continue to get refined. But when you look at all other aspects of life nowadays in the 21st century, and in pretty much every other aspect, things are just easier. When I book my vet appointment, when I order my groceries, when I do anything, it's just easier. I can do it all on my phone if need be, and we're not quite there yet in medicine. Clearly, the data that you've got to review, getting the full clinical picture, it's more complex than any of those things. So I'm not saying this is a trivial exercise, but I do think there's a lot of work that still can be done and should be done. And that's part of the frustration as well.
Chris?
Yeah, physicians, have a tremendous challenge today. I mean, navigating the expanding amount of medical information that's available to them, having to deal with the onerous certification requirements and the increased burden associated with now having to leverage, electronic medical record systems, health record systems, patient portals, all the regulatory requirements around meaningful use and e-prescribing, medication reconciliation, you name it, not to mention just the unprecedented level of scrutiny for quality metrics and patient satisfaction and trying to measure cost. Our organization partnered with HIMSS earlier this year to conduct a survey on just this topic to really try to understand where clinician challenges were on leveraging technology and its impact on burnout. And it was really interesting that out of that survey, 1 out of 20 respondents found that the current EHR was extremely effective. So 1 out of 20 felt it was effective. So the other 19 felt like their solutions were ineffective or really impacted their workflow in a very negative way. And as my colleague said earlier, I mean, those things that are pretty clear: workflow optimization or lack thereof in many cases, ease of portability of data, the tool having the type of intelligence and knowledge to be really an advisor and a resource for them to make better clinical decisions, and consolidating that information in a way that allows them not to have to navigate the full suite of the application to gain that knowledge. And then the fact that it still requires a lot of manual intervention by the clinician to input data takes away their focus from focusing on the patient. And that's where their satisfaction comes from, that interaction that they have with the patient, taking the training that they spent years in gaining and using that training to provide care, and not having to focus their attention on a piece of technology that in many cases can be frustrated. And so, you see these things contributing to physician burnout. And as someone mentioned before, we're just really kind of in the second, third generation of these EHRs in terms of their evolution, and just they've come a long way, but they still have a long way to go. And they are absolutely having a huge impact on physician satisfaction.
Very good, Chuck.
Yeah, from an IT perspective, I actually saw a stat the other day when I was preparing for this. It said that on average, a physician spends 50% of their day interacting with the technology and not the patient. So, from that perspective, what happens is that now you've got somebody who's and again, as Dan and Brett and others said, that, it's important, you've got to work with the technology to document the patient care. But what happens is your day is not 8 hours then. It's 10, it's 12. You're going home, you're working at night, and that sort of thing. So again, that's going to cause sleep deprivation, things like that going forward, which is definitely going to be, part of the physician burnout. What I hear most from physicians that I talk to is really the UI, the user interface, is not really intuitive enough, as I think Christopher was talking about, to be able to get to where they need to go as quickly as possible. And also that it doesn't match their workflow in a lot of ways. And that's a big issue where when these systems are implemented, I don't think enough time is taken to either develop a better workflow and match the technology to it. A lot of times it's matching technology to the current workflow, which may or may not be optimized. So now you're just adding technology onto a bad workflow. There's just, and to me, that's one of the biggest areas that I hear there's a frustration with physicians. Technology always seems to be an add-on to their day as opposed to being complementary to their day.
I just wanted to comment also, just to reiterate, someone mentioned earlier that, the other applications that we use on a day-to-day basis actually have made our lives easier. How much do we now depend on a smartphone to do almost everything in our lives? And we don't have it, we're almost, at a loss as to how to navigate, directions, phone numbers, making appointments, etc. And the EHRs of today have not reduced the cognitive load as of today. And so there's tremendous opportunities moving forward to find ways to optimize those systems, to introduce other technologies like, ambient voice technologies and AI to help reduce that cognitive load so that the clinician can, again, do what they do best, which is focus.
Very good. All right. Next question, Chuck. We're going to go with you. Start off with you on this one. What types of committees or governance structures are useful in identifying and resolving technology-related causes of physician burnout? In what other ways are you working to reduce burnout?
It's interesting, Anthony, that I've never been in an organization that has a committee focused on physician burnout. It's indirectly, right? But it's kind of, I don't know if it's the elephant in the room or it's always in the background, but the committees that I've worked on, the ones we have today, with our physician-led, my CMIO leads a group, is all about efficiencies and things like that. And again, the workflow that I talked about is developing better workflows, changing our EMR in ways to make it easier to use, whether it's ordering, things like that. But it's never, talked about that, by doing all of this stuff, it's going to make the physician more efficient so that it decreases burnout. That's never even been discussed. And I'd be interested to hear from others if that's actually overtly being discussed in meetings. To me, it's kind of behind the scenes somewhere. We know it's all there, and we're trying to make the physician, all the caregivers actually more proficient by using the technology. But we can never just come out and say, hey, we want to reduce physician burnout by X, Y, and Z.
Right. You don't have the physician burnout committee,
Exactly.
the so named, right. Dan?
Exactly.
I think, it's a challenge because the burnout it's multifactorial. I think there have been several studies out now that show that, the computer, it is a component of it, but there's many reasons behind what we're experiencing now. What I would say is two things. So one is just a general statement for what we've done and what I think everyone ought to do. And that's somewhat obvious, which is that you've really got to work with your clinicians. This is not something that the IT team can go think of in the back room. How do we help the docs, the nurses, the other clinicians? This needs to be a collaborative process. So hopefully you've got some clinical informaticians in your organization. If you don't have formally trained informaticians, that's okay. As long as you're involving clinicians, you've got interested clinicians that you're working with, you've got to make it a partnership. Because one of the things that's, I know, frustrating to the clinicians is that they don't understand what some of the constraints are that we've got to work within in terms of our EHR and the other technologies. And so once you make it clear to them, why we haven't done X, Y, and Z in the past, it's because the system doesn't allow for this yet. Then they become a little bit more sympathetic to our plight, and they actually start to think in some more imaginative ways around ways that we could improve on things with the constraints that we've got currently. Not to mention, it gives us more fodder for when we do go back to the EHR vendors to say, hey, can you do this or that? This is feedback from our clinical folks around what might improve things. So that's one. Two, and this is going to what Christopher said earlier. He mentioned about using voice recognition. This is something that we're starting to think about heavily at Boston Children's, and I intend to up in Maine. This is really potentially an inflection point in the usefulness of voice recognition that we're in. Sure, just straightforward voice recognition has been helpful in reducing transcription. But I really do think that with some AI now behind it, as we're starting to see from several vendors, we're at a point where you can envision a future state where the bulk, if not the entire clinical documentation effort is taken away from the clinician. And that's huge. That's like game-changing sort of stuff. So we're very curious to see what's going to happen with the various products that are emerging now. We're piloting. We don't have any real experience yet. We're still in the very earliest phases, but we're very excited to see what's going to come of this. So that's one very direct thing that we're trying that we think is going to really help to alleviate some of the problem.
Very good. Brett, one of the things Dan was saying about getting clinicians involved, and I was just thinking that might be difficult if they're burned out. You're asking them for time and participation, but it's key to improving the situation. Is that sort of a conundrum right there?
It is. And the one thing that you'll find in some of the data is the more a physician is engaged, the more at risk they are for burnout, which may be counterintuitive, but if you think through it, those are the, you end up going, at least in IT, I've got a certain group of cardiologists that I'll go to when I need cardiology subject matter experts or I need to talk to, and that it's tough to expand that pool. But I would agree with Dan. I think you've got to get with the clinicians. You have to partner with them. So you try to get as specific as possible. I think if as an organization, we said, this is the way we're going to address burnout at a very high level, even if physicians are involved, it's going to be really tough because I don't know what that ER doc that works second shift needs versus the pediatrician that's working in the clinic. Those are their burnout needs, even from a technology standpoint, are going to be different. So I would say we have a physician cabinet that has been addressing burnout. It's not a specific burnout committee per se, but I'm not so sure that's not a bad idea. And I, in thinking through this question beforehand, I thought, I wonder, how we handle things in IT in terms of projects and how important oftentimes a project manager is to pushing things through and keeping everybody on track. And because this is so multifaceted, I wonder if one of the structures to think about isn't having a project manager over the burnout situation. And then, there's just little pieces to it. We can improve efficiency over here and we can measure that and we can kind of celebrate that. But then there's more esoteric things in terms of I'm feeling stressed. How do you measure that? How do you know if you're making progress? And a good project manager might be a solution to it. But so, I try to get as specific and as close to the problem as possible. So we utilize our service lines for feedback there, particularly from a technology standpoint, but as a clinician, even keeping my ear to things that aren't necessarily technology driven. And then we have, we're an Epic shop. We have an Epic physician steering council where some of those things that are more global will come up to us and try to address or help. I would agree with Dan huge on the voice thing. I think I've not been as excited for a technology as far as changing the interaction with the patient as voice. And it sounds like we're on the same path. We're just getting a small pilot of 15 providers started here in the next few weeks. Very anxious to see how that goes because I can see in a couple of years that being a game changer. If I don't have to have the aggravation of finding the right chest x-ray in my system. Oh, but you wanted to go there and you normally go, and just like that's maddening. You become a technician, you become an administrator. I want the chest x-ray. That's what I want. If I could do that by voice, confirm that, I understand I'm responsible. So I'd have to push one button to confirm it, but not 20. Wow, that's a huge game changer. Integration is a big piece. When we integrated our PDMP into our system, you talk about something that our providers it was a great thing to announce. There's a lot of things that you wish you had the Kevlar vest on when you go to announce, like the new password policy, but to tell them that our PDMP was integrated, and so as integration becomes easier and easier and more standard, I think there's a real chance to win there. And then one thing that's not technology related, but I try to bring up in a lot of my meetings, with the Cures Act, we just had the whole information blocking piece. We're trying to get ahead of it. We're announcing all these things. Kind of felt like it was going to be delayed, but you couldn't rest on your laurels there. And I'm getting in front of these clinicians and they're acting like, well, they've never heard of it. And they're acting like I came to them with this idea that we're going to release pathology results immediately. And don't you and I'm like, yes. And that's why when the legislation was introduced in 2016, you need to get involved. We can't be as a profession so head in the sand. And whether that's as a CMIO, my responsibility, at an organizational level or others, I just encourage providers to get involved in local organizational, whatever it is. And not even the politics, but just understanding you let other people make these decisions and now you're going to have to play with it. And a lot of times we don't have technology solutions to make it easier. And so that would be one sort of structural piece that's not part of your organization per se. I don't know if y'all have parts of your organization that deal with whether it's lobbying or just making sure that you're up to date on what happens at a state and national level, but it's really important and affects us down the road, even if it's slow.
Exactly.
That's a good point. Try and get ahead of it with being involved with advocacy, so you have some say perhaps in what comes out. Christopher, there were a couple of interesting points by Chuck and then Brett and Dan about not calling this what it is. And
Right.
it's sort of thought-provoking and intriguing. Do we need a committee on physician burnout? Do we need to start using that term? Because then it does kind of cover everything that should fall under there. So what are your thoughts there?
No, absolutely. I think, to piggyback on everyone's comments, you have to look at it really holistically. A lot of times we focus a lot of energy just on one specific part of the physician's experience, and that is primarily the technology. But, many experts attribute about 80% of physician burnout to the chaotic work environment that they're in, and really only about 20% to those personal factors. But there are things like, meditation and eating right and exercise and other stress relievers that, we should be looking at incorporating into the physician's day-to-day process so that they can help reduce some of the tension and frustration associated with just operating in a very chaotic environment. Especially now, I can't even imagine what life is like for a clinician in the world of COVID and the pandemic, and having to manage the workflow and the challenges that exist every day with a disease that doesn't have a cure yet. And so we have to look at not only improving the workflow in and of itself by, reducing the number of needless notifications and optimizing the workflow so that, information is made available in a more seamless fashion, and adopting technologies that hopefully help to reduce some of that cognitive load. But also on top of that, we need to think about the human factor associated with stress, and that is, are there more better mechanisms we can employ that help you manage stress? Again, meditation, exercise. Are you eating right? Getting enough sleep? Having support groups where you can talk about the challenges that you're dealing with on a day-to-day basis with fellow colleagues, and those types of things need to be a part of that whole that new group that you would form around clinician burnout. So it's not just purely looking at technology for technology's sake, although technology should be an enabler and help reduce the stress, and you need to find ways around that. But you also need to look at some of these other more holistic approaches that affects the human psyche.
Yeah, Chris, if I could add, I think that's really important, and you got to thread the needle with it. It's as a clinician, and if you told a physician, you need to relax and get some exercise and eat right, you better duck.
Right.
It's incredibly important, and the person that just threw the punch probably could use quite a bit of that.
Right.
But I think you're exactly right, and if you can do it in a way that is constructive and not seen, while at the same time offering up some technology solutions, I think you're spot on.
Exactly. And so the applications that can now be developed to help, change behavior, tracking what you're eating, tracking your exercise, again, creating a community of folks who are similar people, clinicians, who are all coming together for the same, to address the same issue. I think there's tremendous opportunities to leverage technology, but more importantly, collaborate amongst themselves to find ways to reduce stress.
It's really scary. Let me add one more thing, Anthony. I'm sorry.
No, please.
We just participated recently with the AMA's Mini Z. We have done a bunch of surveys in terms of burnout, but what was curious to me was among family physicians. So we had an N of about 120. The most burned out physicians had been in practice for 10 to 15 years. The most anxious and depressed ones were the first 5 years. By the time you got to 11 to 15 years, you were burned out, but you weren't feeling anything, or you're not feeling anything. And so that's the other piece that's a little scary, is like, if you offered up these resources, you're the most burned out physician in this category, are you even going to recognize that? Versus the early on, they were stressed, they're trying to figure things out the first few years, at least you're feeling something. And so I don't have a solution to that, but that was some interesting data that we uncovered just this last couple of weeks.
Very interesting.
All right. Very good. Very good conversation. Dan, let's start with you on this. How can physician burnout be measured? We love data in IT. How can specific attempts to improve the situation be measured?
This is a tough one, Anthony, because look, obviously, burnout means a lot of things to a lot of people, and it's very subjective. So, at the end of the day, the only way that you can really sort of find out is by asking people. And so, we obviously survey the heck out of everyone. The surveys in and of themselves, frustrate people and probably
Yeah,
burn out. Apologies.
it's okay.
God, I gotta maybe get that.
No
So,
worries.
yeah, pivot to someone else and come back to me. Sorry.
All right, perfect. No worries, no worries. Brett, measuring and attempting to figure out if things you're trying are being successful.
I think some of the IT solutions are actually easier to measure, whether it's time in the chart, time after hours, those kinds of things. We can actually get some objective numbers. You have to be careful because we've gone after what we would determine some inefficient, look at some global data, go after some of the physicians that are spending a ton of time after hours in the chart, only to find out that's their choice. They're leaving as soon as their last patient leaves the door and they want to go coach their kid's soccer team. And so they're going to do the rest of their work later. So you want them to be as efficient as possible in that work, but that work that they're doing after hours may not be, it may be of their choosing. And that was when we were in the paper world. But those kinds of things are a little bit easier to measure. I think when you start just talking about stress levels and anxiety and depressive feelings, that's a lot more subjective. And I think it is tough. I do as much as I can't stand another survey, and we have to be careful to not add to the collective burnout. I think short, focused 4 or 5 question surveys following up on that at a regular cadence is key to knowing if you're moving the needle. And then again, having somebody that tracks that. We do that right now, but I don't have somebody whose job it is until recently. We've got a part-time medical director over physician or provider wellness to track that and then try to move the needle forward where we find our data. Welcome back, Dan.
Dan?
Yeah, sorry about that. Thanks for filling in, Brett. And I apologize if you said this, Brett, but the other thing that I was going to say, other than doing the subjective surveys, is there are some measurements that you can do. They're kind of crappy proxies, but we've all heard the phrase pajama time. The time after hours that clinicians are in the system, catching up on the work that they didn't do during the day. And that's definitely, again, it's a coarse measure. There might be very valid reasons why they need to be in the system. They're on call or some, who knows what. But it is something that in general does tend to track. We found with overall feelings of discontent with the system. And then a super coarse one, but again very real. Brett, you didn't mention. You mentioned the folks just in their first few years of practice, and then those 10 or 15 years. And you also have that most senior category of physicians who've been at it for 25, 30, 40 years. Retirement rate. We've seen clinicians who retire just because they're fed up with the whole thing. And again, I don't think we can blame this all on the computer systems. There's a variety of reasons probably, but they're frustrated. And obviously that's going to be a tough one to see change quickly with tactics that you might use, but over time and maybe aggregated across multiple organizations or around the country, maybe that's a measure that you could look at.
It's interesting
Chuck?
that you bring up
Go ahead, Brett.
I was just gonna say the older physicians, we've had a couple where technology has ended up saving them. When we hit the big telehealth boom like everybody else and we're doing video visits, we've had 2 clinicians that were scheduled to retire in June, ended up trying this new thing, right? And said, hey, I'll do 3 half days from home of this. And so we actually extended their career a little bit with the technology.
It's interesting. I was going to actually piggyback on that. I think there's an opportunity to leverage telebehavioral health or technologies to actually create a mechanism for physicians to get feedback or to provide feedback or get consultation. For example, setting up maybe a quarterly be kind of a wellness check, with clinicians, with a telebehavioral health specialist to talk about, how are you doing? Are you feeling burnt out? Try to understand where they are in that cycle and offer some consultation, some direction for them as they're going through this process, and doing that in a confidential way so that they're not seen as someone, they don't feel like it's a negative thing to have this kind of discussion with, a fellow colleague or third party resource. And they can do it in the privacy of their home or, the office, where again, it's not, being seen by a broader audience. And so I think there's some huge applications for telebehavioral health technologies that help get that insight from those clinicians and also coach them through the stress of a very hectic working environment.
I think that's a really, really interesting suggestion, Christopher, especially if you made it required, right?
Exactly.
You have to, this is something you have to do quarterly. You have to have a confidential conversation with a professional, not shared, but that's a very, very interesting idea.
Right.
Chuck, your thoughts?
Yeah, I've worked on a couple of programs, and actually the one in California is probably mirrors this conversation, and it's similar to what Dan and Brett were bringing up about data, looking at the data. And with the EHRs that were used in California, you had, and in Connecticut as well, but they have what's called signal data, and it captures everything that the physician is doing. And you can start to mine that data and look for trends. You can see how long a particular physician's spending in charting versus ordering. And, within the same specialty, it should be pretty close, depending on what they're doing and the patients that they're seeing. You can look at all that from an analytics standpoint and get an idea of which physicians are being very efficient in what they're doing and which ones are not. And so we actually created a program, West, called Home for Dinner. And the goal was to try to get as many physicians home for dinner. And this was in the ambulatory environment in the clinics, and looking at that signal data and coming up with ways where we could pair up physicians, the ones that the signal data was telling us that were very efficient, with the ones that were not. And that was super helpful. And again, it goes to, I know Brett mentioned the point, some physicians like to work at home after dinner and soccer practice, things like that. And that's fine. That's their preference. But at least using the signal data, you should start bringing this stuff forward and having those conversations to see whether it is something that they're interested in, or, they've got their day all figured out already. But it was a big success out in California. We did it with University of California, San Diego, together. We were on the same instance of the Epic EHR in this particular case, and created this physician efficiency program that was a big hit in getting, docs out the door before dinner.
Chuck, I'd echo that. We've had this similar experience in our shop where we look at some of that data, see where folks are spending, they're at one end of the spectrum where the bulk of the providers are in the middle, and we target our training folks to go and meet with them and ask them questions about how they're working and maybe pointing out things that they just didn't know that were available to them. And it's had really good success.
Yeah, I would just piggyback onto that. Say we've got a sort of a mastery program similar to that. And it's been a nice two-way street learning too. We've got a wonderful training and support team, and they know more than I'll ever dream of how the functionality works, et cetera. But we've learned, I don't want to say as much, but we certainly have learned a ton from our clinicians that have just figured something out and like, hey, that's a pretty good way. We need to get that. We need to disseminate that workflow out. That works a lot better. Or let's get that back to our vendor to work on that software. So yeah, that signal data can be very important, at least being able to target that. What we'll do is we'll look at that and we'll see where Dan might be really efficient or he's not so efficient. And then we actually have a hour or two period of observation where we just go and our team will round with that clinician and watch them interact with the computer and see if what we see on that signal data is just their idiosyncrasies, or if it's truly an area that we could help them focus on, and ask them where they want focused. Sometimes they may have notes that are twice as long as their colleague, but they really want help in something else.
And then from a vendor's perspective, I think it's really important for vendors to establish a relationship with the providers, and those providers become really an advisory group to them, having these advisory boards or advisory committees that provide this input and insight about the product that they're using, so that they can start to develop better solutions, enhance workflows, address some of the challenges and issues associated with the tool increasing the cognitive load on the clinician. So and if you're going to invest in an EHR, then you're investing also in a partnership with an organization for an extended period of time. And it's in both groups' best interest to make sure that the tool is meeting the needs of the organization and not creating this additional stress on the end users. So I would definitely encourage those of you who are with leaders today to become a part of their advisory groups and to provide that direct insight about the design of the product.
Yeah, it's very interesting. The conundrum here, again, it's the people that you need to engage to help you make these things better are the ones that have the least amount of time to engage to help you make the things better. They just want you to make it better without them, but that's very, very difficult, if not impossible. So I think that's, part of what we're all struggling with here. We're going to throw out our little audience poll. So our panelists can answer this as well. Most CIOs underestimate the severity of the physician burnout problem. And Chuck, let's talk a little bit about this. What do you think? You're not an MD. Dan is an MD. Different perspectives there. What do you think is the sensitivity of non-MD CIOs to the reality of this being a problem? If you've never been a physician, if you're not a physician, you might not quite get it. So what are your thoughts there?
I agree. I don't think we do get it because we're not in that world. I mean, I've been a CIO for 25 years, so I work with a lot of physicians, and I follow them around, but I'm not doing that job. But when you look at across all of healthcare, you look at nurses and you look at CIOs, I think there's a lot of burnout there as well. I saw a stat where a third of nurses are burned out. I've talked to a lot of CIOs that are burned out, and maybe for different reasons, but a lot of the same types of things that cause sleep deprivation and things like that. So I think a lot of CIOs, in a lot of cases, we're worried more about our health than the health of the physicians that we work with, because we're under a lot of the same stresses, certainly not life and death types of situations that the physicians deal with, but similar types of stresses. And I think because of that, we focus more within ourselves and within our group, and not so much, not enough empathy, I guess, with what the physicians and the clinicians are going through.
Brett, why don't you give us, Dan, I'll come to you 1 second. Brett, why don't you give us the CMIO perspective? What do you think, CIOs? What do you think? Do you think CIOs get it?
In my organization, yeah. And so it's hard for me to be, paint a broad stroke because I don't know, but I have a tight relationship with my CIO, and she's a very empathetic person to begin with. I guess in my thinking, it's been hard to avoid the press. Maybe it's just as a clinician, I see that in the press, but to avoid the concept of burnout and not know maybe you don't realize how severe it is, but that it's out there. I think the challenge as a CIO would be, I've got some control over the technology, but we just talked about, I got to have the clinician's input on that technology. And then that's just part of the picture. We had the regulatory burdens. We've got the cognitive overload for the EHR, but then other things and chaotic work environment that Chris mentioned. And so it's hard to say, you can recognize it, but then can you take charge of that? And I don't know. Dan, maybe you have an answer to that.
Yeah, no, it's a challenge. I was going to make a snarky remark earlier. That's what I was jumping in for. I was just going to say, look, let's go back to paper and all of our problems will go away, right?
There we go.
And Chuck, I do want to chime in with what you said as well. I don't like this physician burnout phrase because I really do think it's clinician burnout. My nursing and other clinical colleagues have chided me over the years, and I'm well programmed now to just think about clinicians overall, because I do think they're affected as much. In some cases, potentially more. I think nurses interact with our EHRs more than our doctors do on a regular basis. And so they too are feeling it. You know, I see both sides, obviously. I've got the benefit of having the clinical perspective as well as all of the things that Brett, you were just pointing out. And I see, you know, both sides of the coin, and it's stressful. But maybe I'm an optimist. I actually see the potential that we still have ahead of us with respect to our technologies. And, you know, when we think about things like the voice technologies we were talking about before, and all of the other exciting stuff that's likely coming down the pike, I see a lot of promise in the future. And so I do agree that we're not in a great place now. I'm still energized by what's potentially coming. And I try and infuse that sort of enthusiasm to folks that I meet with. And sometimes it goes over okay. Sometimes they're like, yeah, Dan, you're full of it, but I try.
I just wanted to comment also as a former CIO. I used to be a CIO for a large healthcare system, and then I was a consultant at a virtual CIO for a number of different healthcare organizations. I think, as someone mentioned, CIOs can sympathize with, you know, clinician burnout, but a lot of times they feel powerless to really impact it in a meaningful way, because we are to some degree slaves of the technology and slaves of our existing processes, and slaves of what they now call kind of the political determinants of health, you know, the rules and regulations that we all have to now manage, that create more, you know, workload on our clinicians. And so I think there's overall a general recognition and some empathy around that, but these technologies are still to some degree in their infancy. And when you think about where we are in the generation of EHRs, we're probably like in the second, third generation of true EHRs. We haven't been able to incorporate things like AI and other, you know, technology, ambient digital voice digital technologies, and others that will start to reduce some of that frustration, and the EHR becomes less of a tool for documentation and then more of a tool that advises and consults and helps to move the patient along in the process in a more automated way. And so I'm very optimistic. That's part of the reason why I came on this side of the fence from the provider side to now the vendor side, to really start to help develop these technologies and bring them to market and really start to disrupt where the industry is today. So I'm also very optimistic.
All right, very good. Let's look at the poll results. I'm just going to share them so we can move on to other things. 65% agree that CIOs underestimate the severity of the physician burnout problem. All right, I've got an audience question here I want to read. Let me put this over here. The COVID-19 pandemic caused a dramatic uptick in virtual care, which likely caused stress for physicians who weren't comfortable with the technology. Over time, if we sustain a significant volume of virtual care, do you think this will ultimately benefit physicians by improving work-life balance and flexibility? Brett, let's start with you. You mentioned a couple of physicians that decided not to retire because they were able to work virtually. But, you know, again, the conundrum here is, yes, you can work remotely, but just like smartphones did, you're kind of always on. You know, you're always available. So what are your thoughts on that question?
I think it depends on how you structure it. You know, we applaud our IT teams, and rightfully so, that we stood up, you know, telehealth in a week for most of us and had this thousands of visits. And we just assumed that the clinicians knew how to use it and how to, and they became sort of the tech team, the geek squad, right? At the time, they were trying to figure out the patient can't connect, I can't hear you, and figuring all that out. Well, that part was stressful. Mm-hmm. So we looked and stood up a sort of a help desk for the patients to reach out and make sure they could get connected. So again, it's no different than if I'm going to be in the office. The patient is roomed, and the questions that are asked by the MA or the nurse is taken care of, and all that. And I just come in and see the patient. If you can do that, you know, I think it has a huge ability to be a lifestyle improvement. If your organization allows that. I know some organizations that, yeah, they do virtual visits, but it's from the office. That's the only way they do it. So, you know, there has to be some flexibility there, or it doesn't become a benefit for the clinician. And the other piece that we're still trying to figure out, and I'd be curious if anybody else has gotten a better handle on it, is how do you best schedule these things? If Dan's seeing his pediatric patients, does he schedule an afternoon of just video visits? Does he do every third one as a video visit? Because he's still going to have some patients that he wants to see in person. And that's the piece, and it's probably on an individual basis, but when you're trying to standardize some scheduling pieces, so you can do online scheduling and that technology, it does make it a little challenging, and what's the most efficient way of doing that. But I think it's got great potential to improve lifestyle.
Dan, your thoughts on scheduling or the question from the audience that came in?
Well, I ditto what Brett said, that I do think this is a potential positive with respect to clinician burnout and the use of technology to do virtual visits. I think we're still in the infancy stages of this technology. I think, in many organizations, frankly, Zoom, what we're using now, is what's used. Or an equivalent, right? Maybe from one of the specialized vendors. I think these tools are going to get much better and more refined, and they're going to suit the workflows better, both from a clinical point of view as well as for patients and their lifestyles. I think the technology is going to get better to allow us to sort of do a better job at diagnosing and seeing things virtually. There's a company called Untitled Chapter that you may have heard of, that's got these really pretty cool attachments that go onto a consumer phone device that let families do some visualization that's directed by the clinician and or by the software, and allows the clinician to see things in real time with the patient being distant to them. So I do think that it's going to help. I don't think it's going away. I'm still shocked, quite frankly. I think we're a little bit of an aberration at Boston Children's. We're still, and maybe with the COVID uptick again, maybe this is going to be borne out around the country, but we're still seeing about 50% of our ambulatory patients virtually. And I know that that's pretty high for other parts of the country, and even in other parts of Massachusetts. I don't know why. Maybe I like to pretend that it's because we've rolled out just a super fantastic virtual visit platform to everyone. I know that's not really the case, but so bottom line is, I do think that this is going to be beneficial for both patients as well as for providers moving forward. It likely will help with quality of life kinds of issues. Like Brett said, you could envision maybe if the clinician was able to block off a significant chunk of their day that was only virtual, maybe that day is done entirely from home. And that's a nice change for people who are accustomed to having to go into the office every day. So my view is that it's overall going to be a positive.
Yeah. I just want to comment
Chris.
also. Yeah, no, I was just going to comment that virtual care is definitely here to stay, and not primarily because the clinicians are driving it, but really because the consumers are driving it. The patients are driving it. It's now so much more easier for basic ambulatory care for much of that to be done virtually now. Now I don't have to take half the day off to try to get to my doctor's office, sit in the waiting room for an hour, and then to see the doctor for 15 minutes. I can get those basic, things taken care of in a virtual environment, either whether it's a physician or physician assistant or a nurse. I mean, we're pushing more and more the care outside of the four walls of a hospital, especially those services that don't require evasive treatment. And so I do think that virtual care will continue to evolve as these technologies like remote patient monitoring and virtual health assistants and these digital clinical platforms are developed, that makes it easier for clinicians to deliver that care. It's easier for patients to share information. And overall, it creates an experience that's beneficial for both parties. You'll see this become the norm and not the exception post-pandemic.
Chuck, I'm gonna give you one final question. Let you take us out today. I've been following this for a while, more than a few years. I just get the strange feeling that we're just not getting closer. We're not we're not closing that gap between the frustration and sort of improving things. It's almost like when we think we're improving things, the goalpost moves back, either from more regulation or whatever. Do you feel like things are improving, or is, as Dan mentioned and Brett mentioned, are we still hoping for the, ambient voice and all these things, and the cavalry's coming and it's going to be here in a couple of years? But to me, it just feels like we're going to keep running, but I don't know if we're closing the gap.
I think that it's a mix. I think we are closing the gap. I've been a CIO for 25 years. And if you go back to the 90s and look at the technology that we had back then with computerized physician order entry and some of the things we were trying to introduce, it was all smoke and mirrors for the most part. Very difficult to use those systems. I can remember, a lot of physicians basically saying, nope, I'm not doing it. You don't see as much of that anymore. They may complain about it, but they understand how important it is with respect to the patient care in the document. Back then, it was like, no, I'm not doing it. So, we've come a long way with the technology to get physician adoption on a lot of these systems, grumbling in a lot of ways, but adoption. And I agree with Brett and Dan that the technology is we've gotten to a point now where I think the pace is going to pick up with things like voice and AI. We finally got some stuff out there that is going to accelerate the technology so that we don't have to wait 25 years or 20 years to go from CPOE to a fully functioning EHR, right? We can do that in a lot smaller span. So I'm very hopeful that these technologies will come forward and allow us to kind of all have an Amazon experience, with the systems that we work with.
Mm-hmm. Yeah, I would be remiss if I didn't say that DSS and specifically Juno EHR, we like to believe we are the cavalry, and that we are we are coming. We're bringing that type of innovation, that type of out of the box thinking to the next generation EHRs. The current solutions are designed in a very monolithic way. It doesn't allow you to really leverage open architecture platforms to plug in best of breed technology that really extend the reach of care. And that's where we've, and again, I'm not trying to do a sales pitch, but that's the passion and that's the direction that we have, is that we're really trying to turn this whole industry on top of its head and introduce the Amazon experience with the next generation product.
Well, I appreciate you guys bringing us out on a high note and not my depressing, we're not getting anywhere note. So that's a nice way to end it. Regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording of this event is up on our channel. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming webinars. With that, I want to thank our incredible panel today, Dr. Dan Nigrin, Dr. Brett Oliver, Chuck Podesta, and Chris Kunney. And I want to thank DSS for sponsoring and you for attending. And with that, everybody have a wonderful day. Thank you.